very much, and thank you for inviting me. And hopefully in the future, all these wonderful new drugs will do away with bowel problems in MS. But I reckon at the moment, you've probably got quite a lot of patients in your clinics who've got bowel problems. So I'll come clean. I'm not an MS nurse, I'm a continence nurse, so forgive me if I make any absolute boo-boos about the MS side of things. But I have done a lot, both clinically as a nurse consultant in functional and neurological bowel diseases and as a researcher on MS bowels, and seen a lot of people over the years. So I haven't got any conflicts of interest to declare. So what I'm going to do in this session is really give you a bit of an overview, which most of you are probably familiar with, but maybe a bit of reminder of what can go wrong with bowel function in MS. Focus on some research that we've published one study from, and we're in the process of publishing the second paper from that we've done recently, funded by the MS Society. And I think really from a patient point of view, telling you what our research suggests that people feel would help with their bowel symptoms. So, a bit of quick revision. So, as you will remember from many years ago, for those of you all fascinated with bowel function, I'm sure, that if you're looking at the tail end of the bowel, you've got the rectum, stool coming down. When stool arrives, internal anal sphincter relaxes. There are very sensitive nerve cells at the dentate line in the upper anal canal, which samples what's there. So most of us, without really thinking about it, you can tell if it's a fart or a poo or diarrhea coming, and you can take the appropriate action. So if you're in the car on your own, you can safely fart and you don't have to worry about following through. Okay, yeah, my job, you have to call a spade a spade. And at that point, if you're a newborn baby, then actually what happens is nothing, the stool comes straight out. Once you learn bowel control, what you learn to do is voluntary bowel control, mostly but not exclusively, by using your external anal sphincter, which is voluntary muscle around the anal canal. You learn to squeeze, the stool gets squeezed back up, the internal sphincter snaps shut, and you can safely wait till coffee break to actually go and have a poo. Yeah? So does that make sense? That's what most of us can do, hopefully. And actually, we know a lot now about normal so-called anorectal sensation and function. So actually, for most of us, about every 10 minutes, rectal distension, whether it's from stool or gas, leads to a relaxation of your upper internal sphincter, and rectal contents are sampled. So actually, most of us, if you think about it now, this is where people get up and go to the loo, because they go, oh, I didn't realise that. But actually, without thinking about it, it happens at a largely subconscious level, that you sort of know whether you're full or not, whether you're going to have to take the next loo break or not. And you don't become incontinent because your external sphincter is keeping you continent. And you get slow wave activity in that internal sphincter, which actually pushes the stool back up out of harm's way. So you're not like a cat on hot bricks all the time till you get to the loo, unless it's diarrhea. But actually the stool is returned to the upper rectum, sometimes right up to the sigmoid, so on, further up in the rectum, and you're not got urgency to get and find a loo. And then all that's happening usually for most of us at a subconscious level, and normal, anything between 3 times a day and 3 times a week. But I do see in my clinic people who only poo once a week, and it's normal for them. No big deal. That is not constipation. If it's not difficult to go, if it's not causing them a problem, once a week is fine by me. I get a bit worried if they get up to 3 months without going, but we do see in our constipation clinic patients with, the severe end of the market. And then once you do want to go and you're sitting in the right place and with the privacy and so on, you should be able to complete an effortless, relatively bit quick push maybe, evacuation at a predictable time. So there's a lot there that can go wrong. If you think about it, that's a really complex sequence of events that is required for reliable continence. And obviously in MS, you often get the perfect storm of a lot of different things going wrong with either your sensation, with the motor function and your ability to sit on the loo stably, be able to push, with mobility, and mobility affects you in 2 ways. One, you can't respond to urgency, but secondly, you probably get slower peristalsis in the gut. A lot of medications you're on may actually modify your stool consistency to be harder or softer, And then if you are dependent in any way, obviously then the availability of carers at the time when you need them to be able to assist you to get to, onto the loo, remove clothing and so on. And I think all this is really compounded in a lot of patients we see by a vicious circle of anxiety, which stimulates peristalsis, thinking about it all the time. And I bet you're all thinking about your rectal contents at the moment. So, yeah, if you think about it, you feel much more. And actually, a lot of our patients get into a real vicious cycle of monitoring what's there all the time because they've had the horrible experience of an accident. They're thinking about it. That very thinking about it almost makes it more likely to happen because you're monitoring what's there. And then the same things as people without MS. You know, a lot of our patients will have childbirth injuries to the anal sphincter or have thyroid or prolapse or hemorrhoids or blah, blah, blah. So, you know, it's not all MS is the other thing to say. And that sort of diagnostic overshadowing that we highlighted in the NICE guidance on fecal incontinence, which I had the privilege to chair some years ago. You know, we talked a lot about diagnostic overshadowing. Just because you've got MS doesn't mean you can't be a woman with a childbirth injury to your anal sphincter, and that's underlying your problems as well. And I think there is that tendency to assume it's all to do with MS, when sometimes it is, but sometimes it isn't. So a lot can go wrong. And actually, as you know, as well as I do, you know, the main problems we see, and they can coexist in a lot of people, is either constipation or fecal incontinence or urgency. But the constipation can be many types of constipation. We see patients with slow transit where the stool just hangs around longer, more and more fluid taken out of it, and stool becomes harder and more difficult to evacuate. Or it can be more of an evacuation difficulty. And dysynergia. Dysynergia, is that a familiar term for you with mobility generally? You get it in the anorectum. You know, I'll show you some diagrams of this in a moment. They think they're pushing and they're pulling, basically, or they're not relaxing appropriately, in coordination, really. And those two can coexist in the same person to cause constipation, but they may be separate problems. And then the urgency and incontinence problems, and I do find our patients hate the term fecal incontinence. You know, we've done a lot of studies in all sorts of patient groups on fecal incontinence. They will deny it. They will say, oh no, I just have to hurry a bit, or, you know, I may get a little bit of staining. But actually, so we've tended for a lot of patients to be talking more, particularly where it's difficulty getting to the loo in time, in terms of urgency rather than fecal incontinence. It seems to be a more acceptable vocabulary. But that could be because of a motor weakness. It could be because they're not emptying properly. And it could be because they're really, really constipated and impacted and got an overflow, diarrhea, laxatives. We'll talk about that more in a minute, but so many patients are in this sort of seesawing between constipation, okay, give you a laxative, then I'm housebound because if I go out I might have an accident, then I don't take the laxatives, then I get constipated again, and that sort of seesawing between the two, compounded by anxiety. So I'm going to show you a few diagrams just to hopefully highlight your understanding of what physiologically might go wrong, as well as all those mobility and anxiety issues as well. We know quite a lot about these days, especially with the advent of high-resolution anorectal manometry. So we use this fancy probe with lots of sensors along its length, which goes into the rectum with a balloon that we can distend. And this is a diagrammatic representation of the rectum. We've got all sorts of sensors in the anus and then to the outside world. And it displays pressure as a colour contour plot. You don't have to have this fancy kit, but it really helps with your understanding where you're struggling with someone. And I'll show you some of these plots that we get. And basically, the cooler colours, the blues, indicate low pressure, and warmer yellows, reds represent higher pressures. So this is a diagrammatic, this is a printout basically from a anorectal manometry. This is in the rectum, this is the sphincter, this is the outside world, and this is time along here. So you can see this patient's got quite a nice long anal sphincter, 3 or 4 centimetres, with a reasonable yellow tone at rest. And when you ask the patient to squeeze, They can squeeze at will, and they can relax at will and squeeze again. So that's normal. That's what we should be seeing. Good resting tone, good ability to hang on and squeeze that stool back up into the rectum. And then when you distend the rectum, either with stool or with a balloon, you should get a nice relaxation of the anal canal that enables you to evacuate. So this patient's got a normal sphincter tone. When you distend a balloon to simulate a stool arriving in the rectum, you get a nice reflex relaxation. And I'm going to contrast that with what happens with a lot of people with MS, where this is really disrupted. So this is a patient with a neurological problem. Good resting tone this patient's got. Trying to push, you should see a relaxation when you push. And actually, this is what I was talking about, the dyssynergia. So when they're trying to push, the anus is actually tightening up. They're working against themselves. And when I talk to patients about this, I say it's like you're squeezing your tube of toothpaste, but you're keeping your lid on. And in fact, you're keeping your lid on even tighter than normal. So that's why nothing's getting out. So these are the patients who'll sit on the loo for ages. They know there's something there. They really want to go, and they can't push it out because the anus is tightening up when they're trying to push stool out. Other patients, it's a different problem where they've got a reasonable maybe rectal tone, sphincter tone, anal tone here. Patient asked to push and absolutely nothing happens. They're not able to generate a propulsive pressure rise in the rectum and no relaxation in the anus. And you might approach those two problems somewhat differently clinically in the patient on how you'd advise them. With some patients, you can actually train them using biofeedback, and we use this kit to show patients what's going wrong and then help them learn how to generate improved pressures. So when we use them for biofeedback, give them these exact diagrams here, and they lie facing a screen or sit facing a screen. They can see this. And with some patients, you can teach them to generate a better rectal pressure by teaching them how to push effectively, and the anus will relax to let stool out. And with some patients, they don't get a recto-anal inhibitory reflex and this relaxation at a small volume. They require a much larger volume than most people to actually stimulate this relaxation of the anal canal here. And this is where patients who keep trying to poo all day long and they're pushing out little pebbles. Yeah, these familiar, some patients. And I say to them, you really need to save these pebbles up into a decent boulder, because it's actually easier to push out a decent boulder than it is lots of little pebbles. So patients who rush off to the loo every time any little scrap arrives in the rectum, they're actually doing themselves a disfavour if they've got this sort of problem. It's actually harder for the rectum to get hold of pebbles than it is to push out more of a boulder. Does that make sense? Yeah. So I use these diagrams in educating patients as well. Other patients, they've got a really poor squeeze, so they're trying to squeeze, nothing happens. That makes it really hard to control urgency, particularly if some kind person's given you laxatives and you've got a mobility problem. If you've only got a squeeze like that, you haven't got much chance of being able to hold on for very long. And what we're wanting and what we use our equipment to do is teach the patient exercises to improve sphincter function, and especially to improve ability to immediately enhance your sphincter pressures and actually get it kicking in when you need it. So we teach the patient to squeeze. So there's a lot that can go wrong in MS, and we usually start with the really simple things that any of you can do, history and examination. And I would say that although this special kit is lovely, it's not necessary, particularly when you're starting out with someone who's just said, I've got a problem. They are available if you're struggling. And again, don't assume everything's due to MS. But I do think, and this is what patients have told us repeatedly in the research that I'm going to present now, is that we need to be proactively asking people, because this is one of the things. Not all patients, and I know some of them just talk about their bowels endlessly, but some of them really are embarrassed and find it difficult. And in our research, they've said, it's much more difficult to talk about this than it is about pee. I can talk about pee okay to my MS nurse, but when it comes to poo and, I soil myself, that really is difficult to talk about. So not everyone's talking about it spontaneously. So we've completed this study. As I say, we've published the first paper and the second one's on its way. It was funded by the MS Society and aims to cure. And we did lots of interviews, and then we developed care pathway recommendations for people with MS and bowel problems. So in phase 1, we interviewed patients and carers. We recruited through clinics and the MS Society. In phase 2, we took the results of phase 1 and interviewed healthcare practitioners. So some of you might have been involved in that. We had MS nurses, we had continence nurses, we had neurologists, we had other people we interviewed. And then in phase 3, we got everyone together in a couple of stakeholder meetings to try and work out what could we do about bowel problems in MS and recommend care pathways. So one of the very first patients we interviewed in this study, he was up in Scotland. He was a 58-year-old man with quite advanced MS, needed total care. And luckily for him and his wife, she worked for the local council 5 minutes walk down the road. Mixed blessing. He'd had problems with constipation for some time, and he wanted to sit on the loo multiple times a day. And what he'd do is ring his wife up, say, "Can you come and hoist me onto the loo, dear? Because I think I could go now, really." And long-suffering lady, she did this several times a day. Large lad, and it was really quite a palaver, but she was doing this and been doing it for some time. But they talked to their neurologist at a visit, and he started Senna 3 months ago. At the time we interviewed this guy, he'd got diarrhoea 3 to 7 times a day with literally no control on the Senna. When his wife wasn't available because she was in a meeting or something like that, he was phoning emergency social services, and they would go, and they didn't always go very promptly, but they would go. But they said, no, it's not our business to clean up the floor or anything else or whatever. They would clean him up and put him in clean clothing. They wouldn't, so his wife would then come home to, really unacceptable situation. Interesting thing, they'd seen the neurologist several times since that. They had not said that this is what was happening. They hadn't questioned this Senna prescription. Oh, doctor prescribed it, it must be necessary. And we saw that quite a lot of people believing that what they're told was what had to happen, and they couldn't challenge it because, we said to him, "Is this better than the constipation you had before?" And he said, "No way, this really wasn't for either of them. They were really at breaking point when we interviewed them for the study." But actually they said, "Oh, it must be necessary because the consultant prescribed it." And we did suggest, we didn't during the course of our interview suggest that, but afterwards we did debrief with him and his wife and said, maybe you could challenge this and just say, do I really need this much and this often, and couldn't I just take it when I need it rather than all the time? But anyway, so what we wanted to do with our phase 1 interviews with patients and carers was really try and work out what it's like to live with bowel incontinence or constipation and MS, and the ways in which these symptoms impact on the lives of people with MS and their family carers, and find out what self-management strategies they're using and areas where such strategies could be strengthened with a bit more information and support, and what they feel they wanted from healthcare practitioners and organisations regarding self-management. Phase 2, which was the professionals interviews, we wanted to find out how healthcare professionals think about and assess MS-related incontinence and constipation, and how they feel they meet their patient needs. And the third phase was to try and get this consensus on what to do. That was probably optimistic to think we could actually get a consensus, but I'll tell you what we found. So we did semi-structured interviews for phase 1 with the patients, very open, very unstructured. We just went in there and said, what's it like, and then followed up with what they told us. Phase 2, we went to the healthcare practitioners, told them what the patients had said to us, and said, what do you think about this? What do you think about that? And then in phase 3, we presented all the results and see what people came up with in terms of a care pathway. So in the phase 1, we interviewed 41 people with MS, most of them female, and 6 carers. They had a range of different MS severities, types, disabilities, and a range of bowel problems. And these were our themes, and I want to illustrate each of these briefly just by a simple quote from one of our participants. But basically, and probably unsurprisingly, they felt there was physical impact, psychological, social impact on relationships and families. They did come up with some self-management strategies that they were using, and they talked a lot about their interaction with healthcare practitioners and the bowel issue, or sometimes not interacting with people about that. So physical, it varied, but really, I think maybe surprising to me how physical this seemed to be for some people. Calling it horrific, saying it was really painful, it hurts, it's really stuck, and I'm sitting there for a long time and it makes me bleed and it makes me scream sometimes, it's that painful. So really in physical terms, there was a lot of physical, people were getting physical symptoms because of their bowel, and the big ones were pain, discomfort, bleeding, and so on. We actually called our first paper It's Just Horrible, because that's really the overarching thing that came out of this. It makes me cry when they're cleaning me. It's awful to have come to this. And that was a repeated theme, what have I come to? What have I, what is going on here? That sort of loss of dignity, that loss of sense of adulthood, particularly where you needed somebody to help you do it. And you've just got to get on with it. Other people spending literally hours sat on the loo. This was a complete waste of a life for some people, that they were actually, their life and their day-to-day activities really dominated by their bowels. Getting really annoyed with it makes me angry because it's such a waste of time. Social, impacting not only the person with MS, but often their whole families. We used to go away, and now this year we can't do it because it's too difficult in strange toilets. We can't hack it, and recognising the impact on the whole family as well. So it wasn't just the person with MS didn't go away for the weekend, but the whole family and the kids and everyone else not doing it. And this wasn't to do with the MS, this was to do with the bowel bit of MS. Now obviously MS also has an impact on all of this, but a lot of these patients really wanted to tell us it was the bowel that was keeping them home, it was the bowel that was not letting them go to work or go to the theatre or whatever. Probably unsurprising because they knew our interviews were about bowels, but this is beyond the MS impact. A lot of impact on relationships and people's family, just general grumpiness. A lot was described quite a lot. I just feel horrible about this. And a carer saying, I just don't like it, but I have to. It's the only way I can describe it. I have to. So just assuming a carer is going to cope with things like manual evacuation, cleaning up fecal incontinence, even just wiping your lover's bottom is not, I think is above and beyond the call of duty for a lot of people. And this guy at the end here just saying, I feel far more a carer than a husband. And I think that sort of impact on relationships of having to deal with bowel issues. Other people much more positive about it and feeling they would be able to do it. It was okay. And it wasn't too bad, so not everyone was negative. One lady saying, my husband is fit enough to do it, or I couldn't be at home. He was 81 and managing to do it, or you'd have to get the carers in. And I think this last person here, a carer, said it's just something you thought you'd never have to ever do for your partner. You do it for your kids when they're young, but you don't expect to be doing it for another adult. Self-management strategies. Well, a lot of people were completely flummoxed. They didn't know what they could be doing. Very hit and miss, lots of trial and error. I'd like somebody to tell me if there was something I'm missing that I'm not doing that I could be doing. And that was repeated. So some people had found things that work. A lot of people had tried loads of things and nothing seemed to be working for them. And what do they say about the healthcare practitioners? Well, some very positive. They love you guys. They love MS nurses. They love the fact they've got access to you. But in terms of the bowel advice, again, some excellent, but some feeling that there wasn't an understanding really of the impact of their bowel problems. So why would you give someone a laxative to that degree with poor mobility? I was having accidents. This wasn't the same guy as I presented at the beginning. It was another one. And was having to stay in or stay on the loo for 4 hours a day, weren't going out with our friends, just can't leave the house because of accidents. That was quite common. So what do the healthcare professionals told us? We interviewed 19 people, MS nurses, continence nurses, and a variety of other people. And there were 4 themes, which I'll illustrate briefly to you. So, felt that there was a lot of issues around difficulties of service delivery in relation to bowel issues. And MS nurses told us they were so busy with all your lovely DMTs that they just didn't have the time they would like to be able to address bowel issues. So busy with infusion clinics and this, that and the other, they didn't feel that they got the system was enabling them. So should we have a better system? Yes. should be able to support people to be carers or family, but the harsh realities kicked in there and it's not necessarily going to work. Wanting more education, that there's something they can do. Patients sitting in front of you, you know they want to ask something, but you're thinking, oh, I better not, I haven't got time, I've got a waiting room full of patients, I don't want to open that can of worms, so I'll leave it till next time to raise the issue. And the ones on their own, without a family carer, very difficult to organise bowel care very often. And came across repeatedly the amount of time it takes to try and arrange something like anal irrigation at home, trying to get community services involved, you know, and just felt like, you know, a lot of effort and sometimes bashing your head against a brick wall. Shouldn't be like that, but it is. And really attitudes to information giving varied by service setting and the experience of the healthcare practitioners. Nobody tells me anything, I don't know anything, I'm just at the end of my tether. And you know that the patients are at the end of their tether, but you don't quite know what to do about it, or you just haven't got the time and resources to address it. And finding a lot of variability to the importance or priority given to bowel dysfunction, and especially trying to get district nurses maybe involved. You know, they'll deal with catheters, but they really aren't interested in bowel management, and it's an ongoing problem, and the district nurses not dealing with bowels. Others saying it should be a basic, and the continence nurses and the bowel specialists saying, you know, often not being referred patients when they could have been helped. MS nurses tended, and this wasn't exclusive, they varied quite a bit, but seeing constipation as an issue within their remit, but if an individual presented with incontinence, that's when they'd refer on maybe to a continence nurse. And a lot of MS nurses telling us they don't have capacity to provide appropriate follow-up. If they prescribed a laxative, they couldn't necessarily guarantee to follow up and make sure it wasn't creating more problems than it's worth. And the continence nurses really wanting to see patients earlier and be referred these patients earlier, not they were looking for work. So we had 2 consensus meetings and lots of email consultations, and we had 2 separate meetings with groups of MS nurses that some of you might have been involved with. And we couldn't find complete agreement on what we should do about this and who's responsible for what. But we did come up with a draft bowel pathway. I know this is too small to read, but I have got some copies here if anyone's interested afterwards, and it will be on the slides that we circulate. But basically trying to define what could be done at community level or at the MS level, what could be done at the continence services level, and what might require more specialist referral to specialist biofeedback services, and so on, and trying to say, well, right, at baseline, it should be the good history, it should be information, and it should be signposting to self-help information. And I have just contributed to the newest version of the MS Society bowel leaflet, which should be out in a revised version now for patients and carers, and that's a reasonable place to start with a lot of patients. Also identifying what we call red flag symptoms, such as rectal bleeding. Don't forget, just because you've got MS doesn't mean you can't get bowel cancer. So, you know, are there some red flag symptoms that you ought to be asking patients about, and then getting them on a 2-week wait or appropriate referral pathway if they need urgent specialist referral, and how you organise professional assistance with bowel care for those who can't self-manage. The continence services having, you know, more detailed advice on massage and laxatives and rectal medications, and irrigation as well. And then the more specialist services having options for neuromodulation and possibly even considering surgical options. There's a reasonable review, and I've got references at the end of the slides here, from the International Consultation on Incontinence, who reviewed the whole world literature on neurological bowels and came up with expert consensus, because there's damn little real evidence on managing MS bowels, sadly. And they've come up with suggestions for management in the initial phase and more specialist phase. And again, these will be in the slides, but they're talking about what to do with an initial management of neurogenic incontinence in general, not just MS, assessment, thinking about whether you're going to use manual evacuation or digital stimulation, whether you're going to use rectal medications or oral laxatives, thinking, what's the logical thing to do for this patient. And then more specialist management, which might include those fancy tests I showed you earlier. Maybe irrigation. I'd be interested to hear your views on whether that's something you initiate or whether you refer to someone else to initiate irrigation. It's probably one of the most effective routes for patients who are struggling, but it does take a lot of time to get established. And then not forgetting, at the end of the day, there are surgical options in terms of both neuromodulation but also stoma surgery, which sounds horrific, but I've seen so many patients' lives transformed by being housebound with unmanageable fecal incontinence and feeling that a stoma changed their lives. So there's a lot you can do. Start with the basics in terms of establishing a bowel habit at an appropriate time, look at the diet, the fluids, and optimizing their evacuation by talking about how you sit on the loo and how you push, possibly with some massage. Some of your patients, and particularly with the more advanced MS, probably will require laxatives or rectal evacuation, evacuants or antidiarrheals. Some of the patients will respond to either digital stimulation or manual evacuation. I find irrigation works very well for some patients and is a disaster for others, but is worth a try. We use tibial stimulation to stimulate the anorectum, or we can implant sacral nerve stimulators for some patients, particularly with fecal incontinence or biofeedback. And as I say, don't forget the humble stoma. There's a lot that can be done, but how much time do you guys have to really unpick that and think, for this patient, how am I going to approach an algorithm of care? So what we found in our research is this is common. It's affecting at least half of your patients, and sometimes both constipation and fecal incontinence. It has many impacts on your patients' lives. Patients want to be asked about this, and they want systematic help. They want clear advice for self-help. What should I eat? What should I drink? What would help me here? And then clear pathways for professional referral and help if you haven't got the time or the skills to be able to help them. Professionals didn't agree who was responsible for this. Everyone was sort of passing the buck and saying, right, this isn't me, but I'll refer there, and then, I'll refer to the dietitian, and the dietitian saying, I'll refer to the GP, and the GP is saying, no, I'll refer to the MS nurses, and the MS nurses saying, I'll refer to the continence nurse, and the buck didn't seem to stop anywhere. And our next steps are we're going to be trying to compose some more in-depth self-help materials for people with MS and education for MS nurses, but bearing in mind that I know that you guys are already too busy and you really want to take all this on. Be interested in your views. So the references there will be in my slides. So that's our first paper. It's just horrible. The other one is the care pathway we'll be publishing, and these three are some good reviews of what you can do about bowel care in patients with MS. Be very happy to take any discussion questions or challenges indeed. Thank you.